Hey, good morning. How's everybody doing today? It's good to see you. Hope you're having a good Tuesday morning. We are now down to the penultimate lecture. That is the one before the last lecture. Hope everybody's doing well today. See, we had 3 or 4 people in the audience. I'm assuming April Kruger is probably out there today. Maybe Janan Ramos, Christine. Good to see you. Crystal Worsley. Wow. Cool. Good to see all the people here today. Thanks for showing up. Be sure to check this week's announcements. Things are changing because we are in the final week of the semester. Your discussion board is due this week, Wednesday night at 11:59 p.m. Your final homework is due Thursday night at 11:59 p.m. There is no Thursday webinar this week, and the final exam review will be on Thursday morning at 9 a.m. instead of Friday morning. Hello, Karina. Good to see you. Hi, Amber. Just making a few announcements. Since the exams actually the exam week begins on Friday this week, and the semester ends on Thursday, we've moved all the due dates up. Karina and Amber, again. The discussion board is due Wednesday at 11:59 p.m. Final homework's due 11:59 p.m. Thursday. Uh, Thursday night, and the final exam review is occurring Thursday morning instead of Friday morning. Everybody got that? Everybody ready for exams? Yay. I know I'll be glad for this semester to be over. Hopefully, y'all will be glad for this semester to be over as well. All right. No problem. And I put announcements in Blackboard in case you needed to know. All right. For this lecture, we're going to go over and talk a little bit about the people that treat psychological disorders, just as a reminder from last week, and we'll talk about broad approaches to treatment. Okay. Remember from last week, this is the part of the lecture that I think didn't come through well because we were having some technical issues. There are 3 types of specialists that are going to help you when you are having trouble with psychological problems. There are psychiatrists, clinical psychologists, and counseling psychologists. Keep this in mind. Psychiatrists are actually medical doctors who specialize in diseases of the brain and nervous system. They're going to be trained to a certain degree to treat you with psychotherapy, but these folks are going to be the ones that are more interested in giving you drugs to treat your therapy, or giving you surgery, or engaging in physiological interventions. Psychiatrists are different than clinical psychologists and counseling psychologists in that their medical training allows them to administer drugs. Okay, a clinical psychologist. Now, this may have changed here recently. In fact, they were talking about it. But typically, if a clinical psychologist wants to give you a medication, they're going to at least get the rubber stamp of a psychiatrist that they are working with. Okay? So they're medical doctors. Now, typically, you're going to meet these psychiatrists in hospitals. You'll find them a lot of times in hospitals, or in the situations I know, they'll be in a private practice with a couple of other clinical psychologists. They sort of anchor the clinical psych practice, and they can rubber stamp the clinical psychologist's prescriptions that they work with, who need to give medicines. So typically, your psychiatrists are going to treat the more severe psychological disorders. Clinical psychologists are also, you will also find them in, in in clinics and hospitals as well as in private settings. Okay. Now, there are two types of clinical psychologists. I mentioned this last week. There is the PhD clinical psychologist, and there is the PsyD clinical psychologist. If you look at their employment, it'll say the PhD is primarily research in university settings. That's not necessarily true. The reason that you will find them in research settings is that, unlike the PsyD, they have research experiences. So I mentioned this last week, and I don't know if anybody understood it. But in clinical psychology, you go through 5 to 7 years of graduate school, and you actually have to do a research project. And then you have to go through a 1 year clinical internship practicing treating problems. And that was the old model for a clinical psychologist. Now, these people did not have the physiological training that the psychiatrists did because they're not medical doctors, but they did have all the training in treating psychological disorders. Now, they also completed a research project. This was considered the normal way for someone to become a clinical psychologist because Freud, Emil Kraepelin, the early founders of psychotherapy, were also scientists as well who published research papers. So, this is how clinical psychologists were trained for a long time. If you go to the University of North Carolina to get a clinical psychology degree, you will get a PhD and you will have to do a research project. However, it has been noticed in the last 25 years or so that really clinical psychologists, other than doing their research project for their dissertation to get their PhD, a lot of clinical psychologists never, ever, ever do research again. The only time they ever did a research project was in graduate school, and that was just to satisfy a requirement. It's been realized that really clinical psychologists mostly work in applied settings, helping people with psychological disorders. So, a couple decades ago, they created a new degree called a PsyD. You'll notice that it's a little bit different than the PhD above it. It's a PsyD. Now, the only difference between the PsyD and the PhD is the PsyD person does not do a research project, does not have to learn how to do statistical analysis and write a journal article. Okay, they are still developing their clinical skills and they still have to do the 1 year internship. Okay, but they do not have to do the dissertation. And so you'll notice that their program is a little bit shorter than the PhD clinical psychologist. Now, I will tell you that in psychological circles, the PsyD probably isn't considered as prestigious as the PhD. However, in terms of being a treatment psychologist, there really is no difference between a PsyD and a PhD. If you're interested in a PsyD program, Western Carolina has a great PsyD program. So if you want to get a PhD in clinical psychology, you go to UNC Chapel Hill. If you want to get a PsyD in clinical psychology, you go to Western Carolina. Now, both of these people are going to provide treatment in hospitals, clinical settings, or private practices. All right. Now, the difference between a psychologist and a psychiatrist is the psychologist cannot write a prescription for you. Only a psychiatrist can do that. However, I will tell you that the clinical psychologists usually have a bit more experience treating psychological disorders than does your psychiatrist. Where your psychiatrist spends their first 3 years in medical school learning all about the organs and the physiology of the body, the clinical psychologist is going to spend that extra time working on disorders of the mind. Okay? Now, Your clinical psychologists and psychiatrists are going to treat people who are depressed, people who have bipolar disorder, people who have schizophrenia, people who have thought disorders, autism, all of these specific psychological disorders, all of the disorders that you're going to find in the DSM. However, there are problems that people have that are not found in the DSM and are not considered clinical psychological problems. Instead, these people are going to have trouble dealing with things like their family, their job, their marriage. These people are going to have what we would call adjustment problems. All right. Now, if you're having an adjustment problem, you're going to go to a counseling psychologist. Now, if you'll look down below, a counseling psychologist is going to have 4 to 6 years of graduate school developing clinical skills to treat adjustment and life stress problems. Now, most likely they're going to get a PhD, okay, but these people are going to work more in the field of helping people adjust to life stressors rather than treating severe psychological disorders. Now, you'll find these people in universities, colleges, schools, and as well as private practices. Typically, your counselors are going to be associated or attached to environments where you may be having adjustment problems. You may have a work counselor at the big business where you work. If you go to grade school, there is always a school counselor. I think we have some counselors here at Wake Tech which helps students who are having difficulties. So your counseling psychologists, they are going to have the PhD a lot of times. I don't think all of them have to have PhDs, but you're usually going to find them in the applied settings attached to the environment that causes the stress for people. Any questions so far on the types of therapy? Again, this is a review. But last week when I talked about it, I was having technical problems, so it came through all garbled, and I wanted to go over this one more time. We've got 8 people here so far today. Wow! Allison Venegas is here, and Casey. Yanan, good to see you again. How do people know who they need to see? Good question. You typically don't. Most people just know that they have a problem. In fact, a lot of times I'll get students call me who saying, "I'm having this problem. Who do I go see?" Um, as a general rule, if you're just having trouble uh, at work or at home, um, usually your job or your school is going to offer resources, and you may say, "Wow, I'd really like to go talk to that counselor." If you're having just a more serious problem and somebody gets referred to you, they're typically going to say, "Hey, we need to go see a psychologist." Um, it's not that easy knowing who to go see, and a lot of people, I think, pick their therapist sort of at random or based on their friends' suggestions. Um, so a lot of people will go to the phone book and just pick a psychologist out. And instead of looking for a title, Christine, they will look for their disorder. So I'm having depression. So who do I know? And most psychologists are going to list the areas that they primarily treat. Christine, one you mentioned a good question. How do people know who they need to see? A lot of times, well, I won't say a lot of times, but it is considered unethical for a psychiatrist or a clinical psychologist or a counselor to treat a problem that is not their specialty. So let's say you are severely depressed and you go to your school counselor. Your school counselor should be professional enough to know, you know what, this person's not just having an educational problem, but this person has a severe depression. They will then refer you to a clinical psychologist who treats depression. Let's say you go to a psychologist who treats depression, and that psychologist, based on their evaluation, realizes you probably have a thought disorder. That person will then refer you to a clinical psychologist whose specialty is to treat clinical or to treat thought disorders. So if you primarily treat children and an adult with schizophrenia comes to you, it's considered unprofessional or unethical for you to treat that person if that's not your area of expertise. So, for example, my friend, the clinical psychologist, has a child psychology practice. So he treats children who are having behavioral problems, children who are having maybe uh, adjustment problems, kids who have attention problems. If a child was to come to him and show up there with schizophrenia, my friend would refer him to a different person. Yeah, right. You've got a great point. And usually what I found is most students will come to me asking and they'll describe sort of their situation. And then I, as a non-professional clinical psych, I'm not a professional clinical psychologist, okay? I just know a little bit about clinical psychology. I will then try to shunt them to the right person. Most people don't know who they need to see. And that's a great point. And that's why your psychiatrists, clinical psychologists, and counselors are supposed to be trained so that they can identify where you need to be. That's a great, great question. In fact, we have resource centers at Wake Tech. We used to not have counseling psychologists. I think that's changed with the coronavirus. But I think what they used to do at Wake Tech was you would go in and talk to a person that we had, and they would say, you know what, you probably need to go talk to this person or this person or this person. So Wake Tech used to refer everybody out, and it was the intake person's job to figure out which direction you needed to head. And I'm guessing people just start somewhere and then get referrals to find the right one. Yeah, it is a process. Now, I think if you go online or look in a phone book, you can probably, each advertisement in the private practice will sort of suggest what that psychologist specializes in. So if you go look in the back of the book for counselors, you'll see uh, Jane Doe does marital counseling. Um, Franny Smith does vocational counseling. So they'll typically tell you in their advertising, but it's up for you. It's up to you as the client to sort of pick your right area, or hopefully the person that you run into is professional enough to shoot you in the right direction. And the experiences I've had with therapists and counseling psychologists is that they do usually do that. Vart Tech. What do you mean, Camellia Roberts? I'm not sure. Yeah, you start at Wake Tech. That's probably what you meant. Okay, how do we treat psychological disorders? You should already know this because we've been talking about it all semester long. Uh, Clinical psychology isn't a different beast than the rest of psychology. Everything we've learned in the research methods about the brain, about people's levels of stress, about people's emotions, all of the things that we've learned previously in these chapters are the techniques and the knowledge on which clinical psychology is based. So everything that is in chapter 15 has a root somewhere else in the textbook. Treatments for psychological disorders can be put into one of two broad approaches. Let's talk about biological therapies, and we'll talk about what we call psychotherapy, which is some people refer to as talk therapy. So if you remember in chapter 2, we talked about neurotransmitters, we talked about areas of the brain. We talked about neurophysiological problems. So, one area, one sort of approach to treating psychological disorders is to fix the neurophysiological problem that is affecting the brain. So, we think depression is related to serotonin levels. So, a biological approach would be to give you drugs that magnify the serotonin in your brain. We think that schizophrenia is related to too much dopamine in your brain. So, one of the ways we fix schizophrenia is we give you drugs that impair the dopamine functioning in your brain. People with Tourette's syndrome, people with Parkinson's disorder, people that have movement related disorders. We know that the basal ganglia in your brain is the area that moderates unwanted body movement and impulses that you're supposed to control. So we use pacemakers to stimulate these parts of the basal ganglia in order to affect to help people suffering from Parkinson's disorder, Tourette syndrome, or other movement control related disorders. And so your biological approach is going to include drug therapy, electrical stimulation, where we put wires into your brain. And sometimes, although they typically try to avoid this because psychosurgery has so many side effects, we may go into your brain and remove a piece of your brain which is causing problems. So this represents, if you will, a big biological approach. So that's sort of one way in which psychological disorders are treated. On the other hand, uh, there are the psychotherapy or talk therapy. And this is where we go in and we don't treat the problem by trying to change the physiological functioning of the brain. Instead, we talk to people and try to help them come to realizations that help themselves or develop habits that help themselves. And there are three sort of broad approaches to this. One might be called psychodynamic therapy, and we talked about this in chapter 13 in the personality chapter. If you remember, I talked about Sigmund Freud and his conflict related approach. He suggested that all human beings are suffering from psychological conflicts that, if they become too strong or are unresolved, lead to psychological problems. So I'm betting a lot of you who have gone to see a psychotherapist have talked about the conflicts and the competing demands in your life. And you've had your doctor try and help you uncover and deal with these unconscious feelings of conflict, shame, guilt, and embarrassment. Um, Most of the time, these are what we would call self directed or client directed. That is, you go into the psychotherapist and you decide what it is you want to talk about and what you want to share. And psychodynamic therapy or the problem related therapy is only as good as you are honest. If you go into your therapist and keep secrets because they're too embarrassing to talk about, you are withholding the problem from the therapist and you are not going to get any better. Okay, and so psychodynamic or dealing with the conflicts related in your life is sort of one approach to talk therapy. Now, if you remember in chapter 6, we talked about behaviorism and I talked about positive and negative reinforcement and classical conditioning. One major talk therapy approach is the behavioral approach. And the logic here is the problem was learned through environmental exposure. So, how do we fix it? We unlearn the behavior using the same behavioral techniques. There are different forms of this. We talked about systematic desensitization, which, if you'll remember earlier in the semester, we had the lady who was afraid of clowns. And they brought her into the laboratory and exposed her to a clown and helped her work through her strong emotions. There's aversion therapy, where you learn to punish yourself when you have an undesirable thought or impulse. And then a lot of schools and a lot of therapy units use the token economy, which is like small positive reinforcements that you get when you engage in the right behavior or thought pattern. And then what's probably most popular right now is called the cognitive behavioral approach, which is where we combine sort of this idea that we learn patterns of thought, but once these patterns of thought are learned, they take on a life of themselves and become habits. And then we need to identify these habits of thinking and learn how to change them. So, I am so sorry. I'm getting sick. So the cognitive behavioral approach, and you'll notice it's related to chapter 6, chapter 11, and chapter 13. Early experiences create expectations, and these expectations then create schemas. And schemas tell us that we can't handle this, that we are afraid of this, that we are sad about this. And schemas are just habits of thinking. And so schemas affect how we make attributions, the explanation we give for events that occur in our life. This was from chapter 12, social psychology. And I suggested to you that we chronically access negative aspects of the self, your low self esteem part of yourself, the part of yourself that doesn't feel confident. Remember, we talked about working self concept in chapter 13. And so the cognitive behavioral psychologist helps you identify these learned habits of thinking, and then they help you unlearn these habits of thinking. I see Christine Marie has a question here. Are neuropsychologists a new specialty? I've been hearing neuropsychologist, neuropsychologists. I've been hearing commercials for the past years on the radio. Good question. Let's go back to clinical psychologist. Psychology, it used to be the dividing line between psychiatry and psychology was very, very clear, Christine. And psychiatrists were the ones who really thought about the brain and brain functions. And when you went to a psychology program, they really they talked about it, but it wasn't as primary a focus. However, in the last 20 or so years, the knowledge, the understanding of how the brain and nervous system works has become so integrated into the research model of psychology, okay, that psychology programs, clinical psychology programs, social psychology, personality psychology, all forms of psychology, we've now learned so much about the brain that the neurophysiology of the brain is being incorporated into all forms of psychology. So it used to be that that cognitive psychologists just talked about thought patterns, and they didn't really worry about where in the brain thought patterns came from. However, now, if you're going to do cognitive research, okay, you can't just talk about thought patterns. You actually have to tell us where in the brain these thought patterns occur. So now we have this stuff called neurocognition. All right. Social psychologists like me used to talk about how individuals and groups affected people's individual thinking. However, in the last 20 years, it's become important that if you're going to talk about social psychology, you also have to talk about where in the brain social thoughts come from. So, in fact, the neurophysiology of the brain has crept so much into old school psychology that schools are changing their names. So now, excuse me. Excuse me. Carolina has actually changed their program now from the School of Psychology, and to the School of Neuropsychology. So now Carolina doesn't have a psychology program; they have a neuropsychology program. They actually changed the label on the brain. So what's your question you're asking, Christine? Is that clinical psychologists, even though we're not medical doctors, we are now paying more and more attention to the physiology that goes into the psychological problems. Does that make sense? Does that make sense? So I wouldn't say it's a new branch of psychology, but neuropsychology is an admission by your clinical psychologists of how important brain structures are. And we can talk about talk therapy, the psychodynamic approach, the behavioral approach, and the cognitive approach, but you cannot leave out the fact that there is a baseline biological, neurophysiological basis for all of these thoughts. Okay? And I will tell you what your book in chapter 15 is going to refer to as the eclectic approach. The eclectic approach uh, is just an understanding that you can't treat problems just with drugs anymore, and you can't treat problems just with talk therapy. Most of you who have gone to a clinical psychologist have probably received a biological treatment as well as a talk treatment. So, what we call the eclectic approach is an understanding that you have to treat the underlying neurophysiology along with the behavioral symptomology. Okay. Um, Last week, when I talked about diagnosing psychological problems, I suggested to you that we diagnose psychological problems based upon behavioral symptoms, based on behavioral symptoms. So, a lot of therapeutic interventions and therapeutic evaluations were nothing but asking you how you feel and what you were thinking. And really, the evaluation process doesn't take into account any biological indicators of of psychological problems. So, just as I told you, there is no x-ray for depression. There is no blood test for bipolar disorder like there are for medical treatments. We now understand that biological functioning underpins all of these psychological disorders. So the neuropsychologist is just a person who is telling you that yes, I am aware, I am fully interested in the fact that there are biological underpinnings for these behavioral problems that you're having. That was a long answer to a short question. I apologize, Christine. Behavioral therapies. Now, if you'll remember from chapter 6, the lady with coulrophobia, one form of therapy is the exposure therapy. And what they did is they helped people develop irrational fears of objects. And these irrational fears uh, prevent them from confronting these feared objects. So this lady avoided all situations in which there were clowns because she had developed a fearful response earlier in her life, and this fearful response prevented her from ever going into situations where clowns were. So, what her psychologist did was, her psychologist brought her into the lab, and if you'll remember from chapter 6, the psychologist went through and logically explained to her what was happening. Okay, when you see clowns, you have these terrible thoughts, and these terrible thoughts create this really strong emotion in you. And she's like, yes, they do. And the doctor logically, in a comfortable setting, explained to her, you know, these emotions are not going to hurt you. These emotions are natural, and these emotions do fade away. And so the doctor sat down and explained to her what was going to happen when she was exposed to the clown. Yes, you're going to get super duper afraid, but after a few minutes, the fear is going to subside, and you're going to realize that the clown won't hurt you. The doctor then took her into another lab area where, if you'll remember, Giggles the clown came in, and the doctor sat there holding her hand and helped her deal with that strong emotional response. That was what we call exposure therapy. And the doctor exposed her to the feared object and then talked her through her fear response. Once she goes through that fear response and realizes that the object isn't going to hurt her, most of the time, people will get better at being exposed to the feared object. Okay? And so that was a form of exposure therapy. Now, another behavioral therapy is called systematic desensitization. And I think I mentioned this in chapter 6, but I'm going to mention it again. In systematic desensitization, we take a more step by step approach to treating the phobic response. Okay, so if you were going through systematic desensitization, it's gradual exposure. And so, what the doctor does is the doctor will teach you how to relax and then work you through a fear hierarchy. Now, what exactly is a fear hierarchy? Can you folks hear me? Yes, you can. Okay, a fear hierarchy. I'm afraid of spiders. So we're going to create a list of exposures from bearable to too scary. So one might be the word spider. You know, a person with arachnophobia, even the word spider is going to cause them to get a little anxious. And then I might do a picture of a spider. And then I might have a plastic spider. And then a dead spider. And then I might have a real spider in a jar. Okay? And all of these, this is what's known as a fear hierarchy. Okay? And then what I'm going to do is I'm going to take you through that fear hierarchy, helping you relax at each step. So what I'll do is, and this is basically just replacing an old classical conditioned response with a new classical conditioned response. So what I'll do is I'll bring you into the lab. I'll teach you how to relax. Once you're good at relaxing, I'll write the word spider on a board, and we'll practice relaxing. If you get uptight, I remove that exposure away, and we go back to our relaxed state. After a while, you'll be able to relax while you're looking at the word spider. Once we feel comfortable relaxing, looking at the word spider, I'm then going to practice looking at the picture of a spider while we relax. Now, if you get uptight and nervous, I'll remove the picture from your sight, and we'll go back to our relaxed state. And then once we're relaxed again, I'll pull the picture back out. And we're going to practice being relaxed while we look at the picture of a spider. After we get comfortable doing that, and we're good at relaxing while we look at the picture of a spider, we'll then get relaxed and look at a plastic spider, and I'll expose you to a plastic spider. And we'll get good at being relaxed while we look at that. And the idea is to move you up the hierarchy as far as possible. Now, the truth is we can never move anybody to the top of their fear hierarchy, but the idea is to replace the anxiety with lower levels of exposure with the feeling of being relaxed. And this is a classically conditioned response. And the idea is we can get at more serious phobias using systematic desensitization. Both of these therapies use classical conditioning. Remember, which is the idea that the conditioned stimulus, whatever it is you've learned to be afraid of, causes an unconditioned causes a conditioned response. That was initially unconditioned, right? So I remember my wife's grandma Nana, the one that died a couple of weeks ago, when she was a young girl, some boy dumped a cat down, pulled her shirt back, and dumped a cat down the back of her shirt. That cat scratched her up, and the fear of being scratched by something caused her to associate that fear with a cat. And until the day my wife's grandmother died, she was afraid of cats. Now, was it the fact that cats are scary? No. It's because she had a scary event with a cat, and so she learned this negative association. And so systematic desensitization and exposure therapy just try to get you used to having positive associations with the feared object. Now, exposure and response prevention is sort of another classically conditioned response that's used to treat people with obsessive compulsive disorder. And this is called exposure and response prevention. Now, typically with OCD, you have obsessive thoughts you can't get rid of, and those thoughts cause compulsive behaviors. So I may be afraid of dying, and every time I think about dying, I remember that germs cause people to die. And so the obsessive thought, I'm afraid of dying, may cause me to wash my hands. And every time I have the obsessive thought, I have to engage in the compulsive behavior to reduce the anxiety. So obsession, fear of dying causes me to wash my hands, compulsive behavior. And I may have the obsessive thought hundreds of times a day, which may lead to the compulsive behavior hundreds of times a day. Now, in response and response prevention, what the clinical psychologist does is they bring you into the laboratory, they have you engage in the obsessive thought, and then they try to prevent you from engaging in the follow up compulsive behavior. Okay? And so the idea is to break the link between this obsessive thought and this compulsive behavior. And so they try to reduce the anxiety caused by the obsessive thought. So I'm thinking about dying. I know, but you're not going to die. We don't need to wash our hands because we're not going to die. And so you learn how to relax and not be uh, brought into a state of anxiety by the obsessive thought. And they try to break the link between the obsessive thought and the compulsive behavior. Now, if you look at the graph right underneath me, what they're going to show you is that for people with OCD, response and exposure and response prevention is actually way more successful than giving a person drugs. So you can give people drugs for OCD, or you can engage in a behavioral therapy. And the research suggests that the behavioral therapy, when it comes to OCD, is actually superior to the drug therapy. Okay? Now, the big one, the big one, the big one, the big one is cognitive behavioral therapy. Most of you that go to psychologists will engage in cognitive behavior therapy. It is the most popular form of talk therapy. In grad school, all they talked about was CBT, CBT, CBT. CBT is the big one. And it's just an understanding that although we learn positive and negative associations that can impact us, these positive and negative associations become habits of thinking that then take on lives of their own. Okay, so yeah, you may have had some positive or negative exposures that caused you to be anxious, but then you elaborated on these things and developed self structures which incorporate these things. And even when the anxiety, uh, the learned association sort of dies away, you have the habit of thinking. All right. And so this is a combination of behavioral and cognitive treatments, and it was developed from reciprocal determinism. And you can go back to chapter 13, and we talked about it a little bit in chapter 11, which is the idea that our learned associations become beliefs that exist on their own. It's a combination of behavioral and cognitive treatments, and it says that thinking is a learned habit which may or may not reflect reality and may or may not be helpful. So it is not helpful to think that you have no self efficacy, to think that you are a bad person. That does not necessarily reflect reality, and thinking that you're a bad person or a weak person certainly is not helpful. And so when you go into CBT, your clinical psychologist is going to help you identify what we call cognitive distortions, which are habitual patterns of thinking that are inaccurate and also hurtful. Okay, so some people think that they don't have any friends. I don't have any friends. Nobody likes me. I have fewer friends than everybody else does. You know what? That is not true. And most of the time people do that because they don't really have perspective. So you may think I'm not a good person. I'm not smart at anything. And so what the cognitive psychologist does is they bring you into the laboratory and they engage in sort of two processes. What they do is they challenge your cognitive distortion or your irrational belief, and then they try to give you a new habit of thinking. So, what are some irrational beliefs that people have? A lot of people use the words I should or I must. And I must and I should create a lot of pressure on us that really can impair our functioning. You do not have to be anything to make anybody else happy. You only have to be yourself. A lot of times we do not have obligations that we think we do. We put obligations in our head when we really don't. So you do not have to be liked all the time. You do not always have to be treated fairly. All of these, sometimes people have these expectations that are just a little bit too high. You do not always have to be smart. You do not always have to be perfect, but people do that. All right, people put pressure on themselves. You're just a human being. You do not have to be perfect. Some people catastrophize everything. One bad thing happens and say, oh my God, this is the worst thing ever. No, it isn't. No, it isn't. But a lot of times people think about things that way. They catastrophize them. Oh my God, I failed my exam. This is the worst thing that could ever possibly happen. No, it didn't. Not even by a long shot. But a lot of you students out there catastrophize things and think that when something bad happens, it's the worst thing ever. Right? Exactly. Body dysmorphia. Good point. People think that their body is perfect or it needs to be perfect, and if they don't have a perfect look, they may develop these irrational beliefs about their body. Yes, people with body dysmorphia do not see their bodies accurately. Great point, Christine. Now, some people tend to jump to conclusions and assume that everybody hates them, everybody's out to get them, everybody's mad at them, right? And so a lot of people jump to conclusions. You know what? That's the thing that I tend to do. When somebody doesn't call me back, I start thinking that person's probably mad at me. That person probably doesn't like me. And I find that a lot of times I have jumped to conclusions and uh, put motivations on other people that they really don't have. But my own feelings and my lack of confidence cause me to jump to conclusions sometimes. You know, we all think also that we either have to be perfect or it's nothing. If I don't get everything I want, then I didn't get anything I want. That's sort of that all or not thinking. Christine, I always say God hates me when bad things happen, but it's mainly exactly. But you know what? There are some people, Christine, who don't say that as a joke. They really think that, right? You know what? And a lot of people disqualify the positive and focus on the negative. I can't tell you how many people I know that don't pay attention to the good things that they do and instead focus on nothing but the negative stuff they do. This is called disqualifying the positive and focusing on the negative. You know what? Some people think that the world is meant to be fair. Oh, no, it's not, my friend. People are going to be biased against you. People are going to discriminate you. People are going to like you for unlike or dislike you for unfair reasons. People are going to talk about you behind your back. You're not always going to be treated fairly. And one of the things that we need to lose, and that I really want my boys and I really focus on them and learning, is the world is not a fair place, okay? That's a romantic notion that is not true. Sometimes things just don't go right. How many of you have ever been treated unfairly? You've been the best person, but you weren't picked because somebody else was friends with the picker. How many of you lost a job when it wasn't you that made the mistake? How many of you have ever had something unfair happen to you? And you know what? That's just the way it is. And don't take things personally. Most people aren't thinking about you. I a lot of times feel like everybody's out to get Chris Roddenberry, and that Chris Roddenberry is the first thing on everybody's mind. Anytime somebody does something, it's because they were thinking about me. And what I find a lot of times is most people don't spend a lot of time thinking about Chris Roddenberry. So I shouldn't take it personally. Now, what we do with people who have these irrational beliefs is we identify these beliefs. So you're going to go in and start talking to the cognitive psychologist, and they're going to find out which of these habits you have. And then they're going to engage in cognitive restructuring. So we're going to become aware of the use. All right. And then what I'm going to do is I'm going to show you that it's wrong. So you might come into my office and say, you know what? Nobody likes me. You know what I mean? Everybody dislikes me. I will then make you pull out your phone and we'll call the first 6 contacts in your phone. Hi, this is Chris. And we'll talk to that person. And after every phone call, I'll say, did that person sound happy to talk to you? And we'll say, yes, they did. Yes, they did. And we'll go through 6 people that I call. And after all 6 of them sound happy to talk to me, the clinical psychologist will look at me and say, are you sure you have the right reality? People do like you. You know what I mean? Or you'll say, I don't have any friends, and I'll have you, okay, well, write down all the people that you can call and talk to. You might write down 15 people that you can call and talk to. And I'd say, really? Do you really have no friends, or are you just saying that? And what I try to do is I try to confront you with evidence that demonstrates to you that you are not engaging in a rational thought. It's a little bit tricky, but I try to get you to confront the reality of your life and the idea that you are coming up with irrational beliefs. Once I do that, once I do that, we then practice engaging in more positive thoughts. So, my boss yelled at me. That means I'm worthless. That drives me into a sense of depression. And I'm going to reality and say, you know what? Are you worthless? And we'll list all the things that you can do well. And so I'll say, are you really worthless? And you'll say, no, I'm not really worthless. Okay, well, let's practice that. So in your office, I'm going to say, okay, what does your boss typically yell at you about? And you'll say, well, they yell at me here, here, and here. I'll say, okay, let's imagine being yelled at our boss, and okay, we'll go through that thought pattern. You'll say, okay, my boss is yelling at me right now, and they're saying this and this and this. How does that make you feel? Well, I'm starting to feel worthless. Okay, but what do we know? Etc., etc., etc. Okay, right, I'm actually a good person, and my boss is having a bad day. So maybe it's not me. Maybe it's not all about me. I'm taking it too personally. Maybe it's my boss. And so we go through, we sort of practice the thought pattern that you're going to have, and I help you come up with a more positive pattern of thinking. And then what we're going to do is after we practice these new interpretations in the office, I'm going to send you out with a journal. And I'm going to say, okay, every time your boss yells at you, identify that they're yelling at you, identify how it's making you feel, and then let's practice the new thought that we talked about in here today. And so you're going to go out for the week. And when your boss yells at you, you're going to pull out your journal. Boss yelled at me Thursday morning, 9 a.m. My initial feelings are I'm worthless again, blah, 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 blah. What's the new interpretation that Dr. Roddenberry told me? Okay, it's actually probably my boss is having a bad day. I do lots of good things. This is not about me. Do. Oh, yeah, I feel a little bit better. And the idea is that we identify your maladaptive thought patterns. We practice defeating those maladaptive practice thought patterns in the office. And then what we do is we record and try to become aware in day to day life when these automatic thought patterns pop up. And we practice restructuring by using the new thought pattern. And what you'll do is when you go to your psychologist every week, what they'll do is they'll go over your week's events, what happened. That it happened 6 times, and I had these thoughts, and then I tried to practice the good thought after these negative events. Okay, great, fantastic. Let's go over and we'll do a little more reality testing to show you that you are having your rational thoughts. We may practice responding to your boss or to your wife or to your children or to your schoolwork in a more positive way. We'll practice that in our office. And then you go out during the week, and when that event comes up, you become conscious again of the negative thought pattern and try to replace it with the positive thought pattern. And so what we do is we work on developing a new habit over the course of the treatment. All right. Do we have any questions? There are lots of different approaches to psychotherapy. And really, we talked about the ones that are the most popular and the ones that are most well known: psychodynamic therapy, behavior therapy, and cognitive therapy. Humanistic therapy, I'm going to be honest, isn't used a ton, and the outcomes associated with humanistic therapy aren't always very demonstrate that it's not very effective. So I didn't really talk about that. And then there are two different situations where you'll have therapy. Sometimes we have therapy in a group of people who are having the same problem as us, and the idea being that if you hear other people having that same problem, it allows you to develop a little perspective on your own problem. And if the problem is an adjustment problem and it relates to your family or your relationship, it's more important to talk about that problem within the context of the social unit that it's occurring in. And you've got family therapy, and frankly, there's couples therapy, and there's sort of therapy that relates to the social environment in which that adjustment problem is happening. Okay, that's the end of the chapter 14 lecture, the first chapter 14 lecture. On Thursday, we're going to talk, Wednesday, we're going to talk about drug therapy within the context of treating schizophrenia and bipolar disorder and depression. The three disorders we talked about last week in chapter 14, we're going to talk about treating them with drugs. And so I'm going to sort of give you just a general idea to show you how the practice of drug therapy is related to the treatment of psychological disorders. And we're just going to focus on treating these three psychological disorders. The reality is definitely what it is. But the thing is, Ronnie, most people are not escape reality. Most people's beliefs are a little hyper real. That is, we sometimes develop realities that are not exactly true. Okay, folks, I've had a great day. Remember, discussion board is due Wednesday night instead of Thursday night. Your second lecture is tomorrow at 9 a.m. instead of Thursday at 9 a.m. And our final exam review is going to be Thursday morning at 9 a.m. There are announcements on Blackboard which will remind you and give you the details about these things. Please go to your Blackboard announcements and make sure you understand what's going to happen this week since it is final exam week. Does anybody have any questions? If you don't have any questions, I'm going to go ahead and log off. Don't hesitate to send me a text or an email, and I will be more than happy to respond to you as quickly as possible. Hey, folks, have a great day, and I look forward to seeing you tomorrow morning.